Now moving on to some treatment options. So we have Dr. Samuel Reynolds, who is a hematologist-oncologist at Moffitt Cancer Center in Tampa, Florida. He's the lead ECD care physician for the center, and he's going to be talking to us about ECD and other histiocytosis treatment options, current and on the horizon. Welcome, Sam.
Perfect. Thank you, first of all, so much to all of our organizers today. I just want to say how great it is to be in a room with so many of my fellow experts, people I've learned from, been mentored by, and I think most importantly, all the patients. In just 1 hour of conference time so far, I've met some very fascinating individuals who I know have been dealing with this journey for different periods of time. So I thank you all for being here and for supporting the work that we are doing. I have outlined this talk, I hope, to give you a sense for how I view Erdheim-Chester disease, the framework that I use to make decisions. I kind of think to myself, every time I have a new patient in my clinic, whether it's a patient with a very aggressive leukemia or lymphoma, or somebody with Erdheim-Chester disease, how would I explain this disease to that individual, and how would I give them a framework for how to approach treatment? So I hope this overview will give not only providers, but the patients in this room a sense for how I treat this disease, speak a little briefly on clinical heterogeneity, how that impacts treatment, in a very broad overview, giving a sense for how we use genetic sequencing and immunostaining to sort of guide our treatment decision-making. It will not be as granular as we've heard so far, because I believe that the speakers before me did an excellent job with that, and then hopefully leave some time for Q&A. I actually draw this picture for every patient who comes into my clinic. This very sophisticated image of a bone marrow that I've drawn in PowerPoint, because we've seen this a few times. But what I really want everyone to think of is, what does a bone marrow do, and what does a bone marrow make? Hematopoietic stem progenitor cells, better known as stem cells that arise in the bone marrow, will give rise to the constituents of what we know as peripheral blood. Every time you get a CBC at the doctor's office, there's actually a lot of information in that panel. So red blood cells are going to transport oxygen using a quaternary protein called hemoglobin. These are essential in oxygen binding, transport, and ultimately delivery. Platelets are going to be the primary effector of what we know as hemostasis, or the formation of a blood clot at the site of a vessel injury. And then white blood cells are more diverse. They're multifaceted. It's kind of like a chessboard, right? You have your front row of defenders, your pawns that are going to meet bacteria and infection at their onset, and then you have the queen and the king, right? The T cells and the B cells, and then the cells we don't talk about a whole lot, the knights and the rooks, the monocytes that we're hearing so much about, right? So at HSPC, in a broad sense, will become either a lymphoid or a myeloid cell. The diseases we treat are named as such. Myeloid cells will later differentiate and give rise to red blood cells and platelets, granulocytes, or these cells that we call monocytes. And these really become the most important part of our topics for the rest of this conference, right? Because monocytes, when they deposit into tissues, become tissue-resident macrophages, which serve many different functions depending on where they are. I won't get too deep into this because, again, I think we've already had a great overview, but a monocyte that is in the liver is going to function differently than a monocyte that's in the brain. In the context of Erdheim-Chester disease, this can look different in everybody, right? Erdheim-Chester disease in one individual is going to look very different in another individual. Somebody who has Erdheim-Chester disease that's limited to the skin is going to present very differently than someone with ECD that's in the brain, the retroperitoneum, or causing kidney failure. So on a very broad level, it's a very heterogeneous disease. Patients might present with renal failure. Another patient might present with new onset heart failure, depending on the extent of their disease. So how do we treat a disease that looks different in every single patient? Let's start with the framework. We keep it simple. Once we've made a diagnosis, you need to have some imaging. It's not enough to just get a tissue biopsy. Patients really should have a scan from vertex to toe, a bone scan if there's osseous involvement, which there frequently is. If a physician has confirmed that you have a truly localized disease, we're going to start with thinking about local therapies. In rare cases, we can resect and forget about the disease, at least for a period of time. It's not very common, but it happens. Other patients can undergo targeted radiation, and you can observe in very select cases. If a patient has more disseminated or multisystemic disease, or if patients have an accompanying endocrine abnormality, always ask yourself the key question as a doctor, and if you're a patient, always ask your doctor this question. Are the symptoms life-threatening, or is there any end organ dysfunction at baseline? Right away, little self-promotion, I think, for everyone in the room, please make sure you're seeing a physician with at least some connection or who is consulting with an Erdheim-Chester Disease Global Alliance designated cancer center. I believe that we're all kind of interconnected in how we think about research. Yesterday, we had a retreat where we truly made sure that we're all on the same page, and we're working on developing unified approaches for how to treat ECD, so I think this is a very important step. If a patient does not have end organ dysfunction, if there's no life-threatening features of the disease, but the patient is still symptomatic, the patient should still be referred to one of our centers. If truly you have a patient who's completely asymptomatic with no life-threatening issues, in rare cases they can be observed. But let's take the patient who needs treatment, right? Somebody with disease affecting multiple organ systems, critical structures. What's our framework? For every patient, we have to do three things. I do believe that everyone should see an oncologist, whether it's a neuro-oncologist, a radiation oncologist, a medical oncologist like myself. Being seen by a physician, I think, is very important. A hematologist is only as good as their hematopathologist. You should be somewhere where there is a pathologist who's capable of performing the immunostaining that we're talking about, and is going to go a little deeper and look at genetic sequencing as well. We need to understand this disease not only as a radiographic diagnosis and a clinical diagnosis, but truly understand it on a cellular level so we can provide the best care for patients possible. Always consider a clinical trial early and often throughout care. Right away, the first thing we ask ourselves, is a targetable mutation or fusion present? That's usually captured by the sequencing that I talked about, whether it's on tissue, whether it's on blood. We usually have some idea early in the course of the disease if patients have a variant in what we call the mitogen-activated protein kinase pathway or MAP kinase pathway or something perhaps less typical. Regardless, the sequencing should guide therapy. If there is a mutation or fusion present, always try to start therapy there first. This is at least how I approach care. If you have an individual who has access to targeted therapies, I know it's a challenge, I know there's toxicities, and a patient has end organ threatening disease or highly symptomatic disease, I believe the patient should always be offered targeted therapy first. If a mutation isn't present or you don't have access to these drugs, you want to go right to systemic therapy initially. If a patient progresses on a targeted drug or has intolerable adverse effects, the next move should be, first of all, reevaluate genomic data when possible, see if there's any resistance mechanisms that have kind of arisen in the course of treatment for their disease. If none have arisen, go to systemic therapy. And as always, if nothing's working, you've kind of burned through a lot of options, always be considering a clinical trial. It's not this simple. I'm oversimplifying it on purpose because I want to make this presentation as straightforward as easy. But what else do we have to consider? We've seen this chart a few times. These are complex disease states. Erdheim-Chester disease does not look the same as Langerhans cell histiocytosis, does not look the same as Rosai-Dorfman disease. On a pathologic level, you need a hematopathologist to tell you if the cells look different. On a molecular level, you still need a hematopathologist to give you a sense of the comprehensive genomic profile of the individual disease. Every patient looks different. Every set of mutations looks different as well. So what seems like a simple algorithm gets more complicated in clinical practice. Because mutations, I'll just do this one more time. A mutation or fusion guiding targeted therapy leads to a lot of options for us as oncologists. I won't go through every single term here or every single word here, but I will tell you, if you look all the way on the left in the bottom green box here, BRAF or other MAP kinase pathway variants are the ones that are most commonly identified. I think when these neoplasms were first categorized as neoplasms, these were the agents that got approved because these are the most, strongly represented pathway variants. But now we know there's a much more comprehensive genomic landscape available, and it's diagnosable in Erdheim-Chester disease. Patients can have ALK fusions, CSF1R mutations, NTRK fusions, PIK3CA mutations, even RET fusions. And this has led to the difficult to say approval, but I would say expansion of our therapeutic arsenal for many, many different options. Systemic therapy is a very broad term. I think the first thing every patient asks me when I see them in clinic is, what chemo are you going to start me on? I get that question quite a bit. It's like, okay, I know I have cancer. I know I need chemo. What's your plan? The first thing I say back is, I'm going to try to not give you chemotherapy. We certainly have cladribine, okay? We have cytarabine. There's even multi-agent chemotherapy you can consider in refractory cases. But what we try to offer is something not only to target the disease systemically, but we try to minimize toxicity so patients can get interferons. Okay, bless you. There's also sirolimus and mTOR inhibitors that we can utilize. So there's a lot of options that I would call systemic therapy that are not chemotherapy in Erdheim-Chester disease. In general, and this isn't captured fully on the chart, but in general, most of the targetable mutations are felt to be indefinite or continuous. We're working on models to examine time-limited courses of therapy, whereas chemotherapy is more limited. But of course, relapses and toxicity are more frequent. But in general, this is a framework that I hope you'll find helpful in what the treatment options are in Erdheim-Chester disease. In terms of what's on the horizon, I think many of these kind of represent our current horizon, but I think at least the way I think about it is we're working on more targeted therapies to go after the source cells of everything in terms of targeting monocytes and potentially even looking at combining different agents or repurposing other agents for, say, myeloid or lymphoid neoplasms. I treat leukemia every single day, and most of my research is focused on the intersection between leukemia and histiocytic neoplasms. So I hope in the coming years we, and I hope myself, will have more to offer in the way of therapeutic options for ECD. This is just, I hope driving home that it's complicated. It's not a simple decision. This is actually from our own internal practice guidelines, our own national comprehensive cancer network guidelines. When a physician in the community, maybe someone who isn't an ECD specialist, is trying to determine how best to treat ECD, this is actually the chart that we're looking at. Okay, it's very comprehensive. It's essentially a list, but in clinical practice, the decision is much more nuanced. And of course, we always have to keep in mind the danger and the ever-present problem of financial toxicity when we make therapeutic selections. With that, these are a few of my references. Many of the names you see on the screen are people who are sitting in this room right now, so truly I want to thank all of them. I want to thank everyone in the ECDGA, especially Goravan, Paul, Diane, and Jerome for everything they do. All the physicians I work with at my own center down in Tampa, everyone I've collaborated with and learned from at the University of Michigan, especially Azra, who's here today, Rebecca Jithma and Reynolds, thank you for your support as well, and I'll take any questions.